So we're actually much more interested in a broader look at the tumor microenvironment, and we're doing that via gene expression profiling. So not to just look at one gene or one set of cells, but rather look much more broadly at the full transcriptome of the tumor, which genes are up and which genes are down. So much more big picture view of whether or not immunotherapy is likely to work. We find those patients who have what we call a T-cell inflamed tumor microenvironment to be much more immunotherapy responsive. And on the flip side, if a patient has a really non-T-cell inflamed tumor, there's no lymphocytes in the tumor, immunotherapy basically doesn't work. And so I think that's a better model. It's just a little more complicated. It hasn't yet become really a clinical grade diagnostic, but over time perhaps it could. So if we had a useful clinical grade test, perhaps those patients who are the most highly T-cell inflamed in their tumor might be candidates for anti-PD-1 antibody alone, as opposed to perhaps those who have less inflammation perhaps need the combination up front of CTLA-4 and PD-1 blockade together. And as we sort of go into the next generation of combination strategies, 4-1BB, OX40, GITR, all these other things, we're going to really need to be able to sort of piece out a little bit more how much push do you need to give the patient, right? So if they're already quite inflamed, maybe PD-1 alone is very highly efficacious. Whereas if they're much less inflamed, maybe all of these combinations might be what we need to think about.